Welcome to the Cities Changing Diabetes program, a public-private partnership between Steno Diabetes Center Copenhagen, University College London and Novo Nordisk, established to understand and address the complex challenges of urban diabetes. Cities Changing Diabetes was launched in 2014 in response to the recognition that new solutions were needed to the growing global challenges of diabetes and obesity. As of mid-2021, the program is active in more than 35 cities across the world, where we design and implement innovative solutions to prevent urban diabetes in partnership with local municipalities, universities, NGOs, community groups, and more. But why focus on cities? Well, cities are where more than half of the world's population lives and where 2 in 3 people with diabetes reside. Therefore, we believe that the biggest changes can be made in the world's urban areas. In order to design successful intervention, it requires an in-depth understanding of the local context and the risk factors that make people vulnerable to diabetes. To achieve this, Cities Changing Diabetes uses a 3-phase approach called Map, Share, Act. In this video, we will take you through these 3 phases of mapping the challenge, sharing knowledge, and finding innovative actions to curb the growing diabetes curve. I'll start by showcasing what we mean by mapping, both globally and locally. According to the International Diabetes Federation, the global prevalence of diabetes has doubled in the past 19 years, rising from 4.6% in 2000 to 9.3% in 2019. If this trend continues, the number will rise to almost 12% in 2045, affecting more than 700 million people. Addressing this challenge requires more than just treatment. We must identify the factors that increase the population's risk of developing diabetes and seek to prevent exposure to these risks. In addition to quantifying the diabetes burden, we must also apply a qualitative perspective. In our original research, we identified 8 social and cultural indicators of vulnerability to diabetes that cut across several of our cities. Vulnerability is defined by more than biomedical factors such as age, BMI, or physical activity levels. It is social factors like financial, geographical, time, or resource constraints, and cultural factors which include traditions and conventions, view of health and illness, self and others, and finally, change and transition. Across the cities, we additionally found 3 cross-cutting factors that were especially pronounced, namely social isolation, mistrust, and time poverty. To establish an overview of the local burden of diabetes and obesity, we need to answer the following question. What is the problem? Where is the problem? Who does it affect? And why does the problem impact these groups? To understand this better, let's look at our partners in Houston in the US to see how they mapped their local challenges. Houston has a diabetes prevalence of 15.6%, which is projected to increase to over 20% by 2045. A key contributor is obesity, affecting around 1 in 3 of the adult population. Here we have identified the what component of our problem. But why are people from Houston at such high risk of developing diabetes? We know that in Houston, inactivity combined with unhealthy diets has resulted in one of the highest obesity rates in the US. However, we needed to dive deeper to understand the root causes. Therefore, we conducted a diabetes vulnerability assessment which included 125 interviews with residents from within neighborhoods considered vulnerable to diabetes based on clinical predictors of diabetes and on economic disadvantage. Here we have identified the where. The vulnerability assessment was used additionally to identify 4 distinct profiles of diabetes of high risk of developing diabetes, and there we had the who of the problem. The research revealed several vulnerabilities including low health literacy, long commutes, unhealthy food traditions, and living in neighborhoods undergoing constant change. Surprisingly, the risk of diabetes transcends economic lines. For instance, Some young professionals were vulnerable to diabetes because they were too busy to make time for healthy diet and exercise. Further research revealed a lack of trust in the formal healthcare system as an additional vulnerability factor. Now, in addition to the what, the where, and the who, we've also identified the why component for a more complete understanding of the problem. These key insights serve as the foundation on which we can move into the next phase, namely share. We now have a better understanding of the problem, and we want to identify those who can help us solve it. In Houston, we've learned that faith is a deeply integrated aspect of daily life. More than 2/3 of Houstonians say that they attend a religious service at least once a month, with 42% attending at least once a week. Faith communities provide a unique sense of safety, commonality, and trust that is missing in, for example, business, educational, and health settings. Faith is an integral part of the social fabric and also everyday life. Therefore, a clear opportunity exists to bridge the gap between the traditional health system and communities of faith. In this way, we can reach populations that have previously been excluded from or skeptical towards conventional diabetes education programs provided by healthcare professionals. Using this insight as a starting point, the Institute of Spirituality and Health at the Texas Medical Center was chosen to coordinate and set up a backbone organization to help convene stakeholders and start discussions on how to move forward. An action work group was formed around it, with more than 75 actively engaged participants representing more than 60 organizations. Houses of faith from several different religions, government bodies, health insurance companies, medical providers, employers, and non-profit entities were all involved. The Action Work Group's role was to assist with the translation of research into interventions to be further developed, implemented, and owned by the Houston stakeholders. Identifying who to work with and how is key to a strong program. In Houston, a City Connector role was established in order to identify stakeholders, help structure the partnership, and make ends meet. Our partners in Houston made a short video about their local City Connector, Klaus Kreuer, and it explains why it can be beneficial to invest in City Connectors in more cities. Let's hear a bit from Houston about how this works.
He's the glue. You know, the connector, as you call him, really holds the collaboration together.
Something that I think has worked really well in Houston is having a city connector. Having a city connector has been amazing.
As a city connector, you get to work with all kinds of people, from the highest level of public officials, healthcare executives, business leaders, community-based organizations, and people with diabetes who are just concerned about how they can improve their lives from the state that they are at right now.
When you have so many partners that are so diverse, and you have a diverse group of participants, organizations, you have to have someone like Klaus, someone that becomes your liaison, your connector to hold us all together.
We're able then to call on this person to say, I have this idea of who might be the best person for me to talk to about it. Can you make that happen? And usually the answer is yes. It's made the work not only easier, but also more of a joy because we're able to make more connections. We're able to be more creative about the projects that we engage in because some of that administrative burden and responsibility is lifted off.
Every day is different. And when I talk to my friends and my family about what I do with Cities Changing Diabetes, they are amazed about the rich variety of people and projects I get to work on. It's very energizing for me to be exposed to different types of people, get their perspective, and improve my understanding of Houston and the people here. And when I meet other folks in the community, I can bring some of that knowledge along. then it's easy to make Cities Changing Diabetes as relevant and meaningful as possible for that particular stakeholder, that particular volunteer. Each city that's participating in Cities Changing Diabetes is different. There are local customs, local culture, and there's a local way of working together. And when you develop a coalition, you have to do it in the way that's appropriate for that particular city. In Houston, it has been beneficial to have a city connector because I have an independent role. That has given me access to different stakeholders because they don't see me representing the product of Novo Nordisk. They see me representing Cities Changing Diabetes, which is really focused on prevention and making life much easier for people who are at risk for developing diabetes or people who already have the disease.
I would strongly recommend that other cities establish a city connector type role, and I hope that other cities can learn from Houston and its success.
We could not have done and been as successful in Houston without Klaus.
One of the important lessons from Houston is to establish an in-depth understanding of the needs of the people and to make use of assets available locally. From here, we can co-create tailored interventions together with the target groups that are adapted to their own setting. This is done in the ACT phase. Here, we built on what we learned in our mapping and sharing phases to develop an intervention that addresses the problem. In Houston, the Action Work Group utilized the research findings and their knowledge from their own community to design an intervention to address the local needs. As a result, the Faith in Diabetes Initiative was launched, which assists houses of faith across Greater Houston by developing a range of diabetes prevention and awareness tools that they can share with their congregations. At the heart of the initiative is the Congregational Health Leadership Program, a 4-step diabetes-focused training program. The program supports community actors and faith leaders in empowering their congregations to lead healthier lives by, for example, improving awareness of diabetes risk, educating about healthy habits, training diabetes management skills, and improving health literacy. By following the Map, Share, Act approach, Cities Changing Diabetes Houston was able to create a truly context-tailored and locally driven program that responds to the needs of their most at-risk community members. In order to assist other cities in following Houston's example to create their own initiatives, Cities Changing Diabetes has developed the Urban Diabetes Action Framework. This framework draws on our experience in cities including Houston and is inspired by other intervention frameworks within public health, climate change, and urban design. The Urban Diabetes Action Framework outlines a 6-step process for translating research into action in order to promote good health and well-being, prevent disease, and reduce the inequality gap. To illustrate how this process works, let's return to our Houston case. Step 1. Defining the problem. In Houston, we discovered a high prevalence of diabetes that is projected to increase significantly in the coming years. They also identified several vulnerability factors related to type 2 diabetes. Step 2. Securing commitment. In this step, they formed the Action Work Group to gather relevant stakeholders who could reach the community and address their needs. Faith-based institutions were identified as key actors that could drive health behavior change among vulnerable communities in Houston. Step 3. Design the intervention. Here, they chose to focus on the gaps in health literacy and diabetes knowledge, designing a combination of training and education programs in local congregations to improve health behavior. Step 4. Prepare a plan. Recognizing the importance of faith-based community leaders as a trusted source of health information, they decided to conduct a training of trainers to support faith leaders in empowering their own congregations with education and awareness-raising sessions. Step 5. Implement and monitor. In this step, the plan is put into action. The training sessions are rolled out, and the Action Work Group monitors the process of the intervention. To date, These trained leaders have the capacity to reach 75,000 Christian, Muslim, and Hindu residents of Houston. Step 6. Evaluate and sustain. The initiative is currently being evaluated and is showing promising results. Preliminary evidence indicates positive changes in the participants' diabetes-related knowledge. Training community-based leaders contributes to the sustainability of the program as they can take ownership in improving health literacy and knowledge among their own congregations. This is not a fixed order, nor is it only related to diabetes. In reality and in Houston, the development is not linear, but often an iterative cyclical process, and this is very clear from our global network. Being part of a strong global network of partners means opportunities for sharing and learning are significant. For example, community programs in Leicester were inspired by the Faith in Diabetes program we've just heard about in Houston. Our partners in Rome shared the learnings of their work with Manchester. And finally, we saw that Mexico City and Houston have collaborated through a shared research hub. In this video, we've showcased one example out of the many that exist within the Cities Changing Diabetes program. Though each program is unique in its own way, the 6-step framework can provide guidance for the development of evidence-based interventions tailored to any local context. We encourage you to engage with our action framework and its resources and available tools as an inspiration to address the health challenges present in your own city. Thanks for your time.